morning, everyone.
Good morning.
Good morning, everyone.
Good morning.
Thank you. I'm Edward Dadari. I'm with the Department of Mental Health. I'm the district chief. He's the regional manager for SPA 4, this area that we're now sitting in, of course. This is Jim Gilmore, and Jim and I are going to be talking together with you about a few issues. I'm going to let Jim introduce himself in just a moment. I've been the district chief of the Department of Mental Health here about 3 years now, and before that I was the district chief for several years. Actually, it's been longer, that's like 4 years. And before that I was district chief in SPA 7 before coming here. Jim, you have to say a few words about yourself before we launch into...
Good morning. My name is Jim Gilmore. I'm the Director of Corporate Development and Training for Behavioral Health Services. We are a large provider of substance abuse and mental health services in the county. We've been doing a number of these things for years. The BRIGHT program is a project that we've been working on for the last 4 years. It is a research project that we've been working on with RAND. And the results have been extremely promising. We're about ready to publish the final results of that in the next coming year, but what we've seen so far has been really effective. We do have a couple of folks, a couple of the counselors that were trained in the BRIGHT program here today. They're going to be part of the CBT workshop later on. I just want to say real quick, because in this discussion, I'm going to kind of represent the CBOs, those of us that are out there in the community trying to keep our doors open and to provide services with shrinking dollars constantly. We're all aware of what's happening at the state level, and it's making it really difficult to do what we do. One of the things that happens is what was mentioned earlier, that when you get funding, especially public funding for anything, it kind of it comes with some regulations and restrictions, which kind of by its nature create these silos where you're kind of only allowed to do whatever it is you do, whatever it is you're funded to do. And at least out in the community, many of us have been forced to kind of figure out some ways to get around that barrier, because funding has kind of become a barrier rather than a help to us in a lot of ways. So we've had to really look at how can we work together, how can we find other folks who do some of those things that we need that we can't do because we don't have the funding to do. So that's kind of how we get involved with this whole collaborative process, and it's kind of gone on from there, and I think that's something that we want to talk more about today. So,
Thank you. The Department of Mental Health, of course, receives funding from the state and the federal government, and of course we get some funding from the Board of Supervisors. But we too have been struggling with shrinking resources, as you all know. Many of you are providers who are contracted with our department to provide mental health services in the community. So what Jim has said is true not only for CBOs, but also for county departments and the agencies that work for them. And yet within these limited resources, we've been trying also to do many of the things that Ken and Elizabeth were talking about earlier. We've been trying to collaborate with others, to create a fuller connection with other services, because we clearly understand that people don't get better concerning their mental health issues if they're struggling at the same time with housing and unemployment and education problems and all the other problems that can be confronting a person. So we're trying to put those things together. So we're so happy to be working with Ken on this pilot, because it's right in the direction that we've been trying to go ourselves already. Now, if you've looked at your schedule, you'll notice that the reason that Jim and I are here talking is to address, not to address actually, to lead a discussion about the issue of depression care in our community. What are the issues, the problems, and the potential solutions? So that's the focus we'd like to bring today, and ask you to join with us in a conversation about what is the state, what are the resources that we now have in the community. And maybe to really bring it home, to ask yourselves this question, and then I hope you can share with us your perspective. And the question is, how are you today handling how are you today addressing depression when it comes to your attention? How do you help the person with depression when it comes to your door? What are you able to do today to address those needs? Can I turn to you and ask for some volunteers to share with us what you're doing or able to do? Yes.
And this is a very common experience for me, that clients come in, and I don't find that many are in denial about depression. They use the right word. They say, I'm depressed. I have to honestly admit, I've been doing this work. I'm a parish nurse. I'm a nurse who works in churches. That my internal thought is, oh no. Because I have hypertension, I can send them to a clinic. It may not be easy to get them and look it in. With depression, of course, one part of it is trying to listen to them, just show some empathy. Sometimes that helps. They come back and they seem to like us. They come back. That's one sign. There must be doing something, how they're coming back for more. But I also have clients waiting, and it's not much privacy, so they only get a few minutes of whatever empathetic listening I give in a very unprofessional way. But what I also try to do then is send them somewhere. Like, is this a big enough problem that you would like to do something about this, like go somewhere? Then the question is, where can I get them? And when I call, I often find, when no one answers, I find they don't quite qualify. I find that yes, they're available to have a service, but it's a long time in the future, or that it costs more than they can afford. So I often end up, encourage. I work in churches. I say, well, there's a church here. There's always prayer, and there's always a pastor, and that's a resource available nearby. And one I know they're comfortable with because they're always showing up in churches. They're pre-selected in that way. So, I think it's a lot better than nothing. And I think it could be a lot better than it is.
So just to recap. Stereo. So just to recap. You do listening, empathetic listening. You provide support. People return for a second visit oftentimes, or even third and fourth visit. You try to make a referral, which sometimes works and sometimes doesn't. And you turn to the church, prayer, the support of the community that is the church. And those things all
As
happen.
I mentioned before, habitual DUI offenders are seldom clinically depressed. Probably only 2% of them are depressed. But if they're depressed indeed. They're somewhere in the rock bottom of depression where they don't care if anything happens to them. They're desperate. But what I do, every time I see the client the first time for assessment, I have a bunch of paperwork. And if there is any indication in the paperwork that the client is depressed, I immediately give him or her the back depression inventory. And I trust this test and go from that. If one is depressed, I make a referral or try to introduce the idea of seeking psychiatric help the best I can. And I'll give you an example. One time I saw a client for assessment, and the agency policy is to kick out of the office anyone who seems to be under the influence. She was. But she was so severely depressed that to kick her out is to doom her to suicide. So I completed the assessment against all the rules. I made all the recommendations, and she was struggling. But eventually she got help from Clear Foundation. But if there is any indication at the time of your assessment that one is depressed, do your best. Do your best to help the person, because you don't know what's going to happen to him or her once they're out of your office. They might go out and check themselves out.
Michael, you mentioned that you make a referral. What do you use for referrals when you give someone a bed condition?
Okay. I immediately try to find out if one has a health insurance and what it covers. Now, also, some people who come to drug and alcohol counselors are in therapy already. And what is troubling here is that some therapists never ask or acknowledge the fact of substance abuse. If you have a substance abusing client in your therapy, treatment, or whatever, and one continues to use or drink, you are wasting his time, your time, and money. One has to be clean and sober first for any other treatment for anything ever. Thank you.
Okay, thank you. Okay, we've heard from a nurse and a substance abuse counselor. How about someone from another? Go ahead. Oh, sorry.
Okay, I deal every day with moms, postpartum depression mostly. It is very difficult for us to find out through the pregnancy because of the hormone imbalance and all that. But once they have the baby, what we do, we right away use we call the PHQ-9, and that's where we base ourselves. And as we do the math and we see the results, that he says we look for resources, which is very difficult because we usually, it needs to be in some type of crisis or have other mental issues in order for them to be taken. But what we do, we try to call and find places for them they can receive some type of therapy or if they need medication. But our first step is to do the assessment and try to do the correct and knowing that it's not only something that's postpartum blues instead of postpartum depression.
Okay. Anyone else from another discipline?
If I could recap just for a second,
Oh, I'm sorry.
that's all right. Resources for the pregnant or the newly delivered mother, there are not too many. There's not, the status in our community is that there's not many places to go.
We don't have much either.
Yeah, in the work that I do, I'm a marriage and family therapist intern. After doing the assessment, I find out a little bit more about the depression, the onset, if there were any specific triggers or incidents that occurred just prior to the depression symptoms. And then also, because the model that I work from is strength-based, I want to know all the things that they've done in the past that have worked to decrease the depression and build on that. So trying to identify triggers and then building a treatment plan to increase their coping with the depression.
So if I could recap, using a strength-based approach to try to increase their coping skills.
Okay.
At St. John's Well Child and Family Center, when a patient comes in, they usually tend to see the primary provider. They report some depression, or either the provider screens for depression by using a PHQ-9. Then there's a warm handoff that's done to the clinician, which is myself. And then from there, I meet with the patient, go over the PHQ-9, and begin some CBT immediately. Defining what depression is, what the symptoms are, also addressing their strengths, but ensuring and recognizing their strengths so that they can themselves start to do some self-action or start addressing depression, and then following up with appointments bi-weekly.
Okay. So you actually are one of those resources that folks would refer to.
Yes.
Okay, how about someone else in another discipline that you run into? Are there any, like, doctors here or nurses? Nurses? Oh, you talked about it already. Anyone else? How about the faith-based community? We talked to a nurse from the faith-based community, but someone else from the faith-based community. Do you encounter folks with depression, and then what do you do?
Well, I am neither a doctor nor a nurse, but I'm a priest. So I think from a spiritual point of view. Earlier on, so many people come to the office to present their own problem of depression. For me to attend to them, I have to learn what depression is all about. Then I have to make some studies, personal studies, on what depression is all about. I happen to come different articles in the magazines, in the books, that treated on depression. Therefore, I was prepared. Then at long run, I continue to develop my own way to attend to them because they are quite different cases that come. There is what I call picture therapy. Hereby, the person comes at the initial stage, especially the women. When you see a woman who is depressed, you will know. Maybe you begin with a lack of self-esteem, lack of taking care of herself, the hair, and everything. You will see some changes. Then what I do you want me to take you some picture? Okay, then after long, I will convince the person because I know I had to. Then I take the picture and then I keep it. I will tell the person that the problem you're having now began quite long ago. Therefore, I can't solve it within a minute. Therefore, you have to come repeatedly for once a week or twice a week or thrice a week, depending on the type of case that I saw. Then after some time again, I will take another picture. After a week or 2 weeks, I will take the picture. Then the person will come again, probably in 3 weeks. And I will now take out the picture, I will print the two, make a comparative study of the two, and then ask the person, now, which one do you like best? Do you like this, the old, or do you like the new? 80% of the people, they say no to the old one, then they want to way forward. So that's one of the ways I do the picture therapy. Another system is to excavation, to know, because there is a cause, and also after the cause, there is an effect. There is an action, and also the reaction is caused because of the depression. Therefore, something definitely must have led to a situation like that. So what I do what I call excavation. I excavate with the person to know actually when the problem began. I also have some unpublished write-ups that I made. One is on human problem. Human problem is an unescapable reality in our human nature. Therefore, I have to go with the person towards the past to see whether one time or the other, he or she has had some problem which he was able to manipulate. Because depression is just like a rock. Comes through sedimentation of emotions unresolved. Therefore, I then have the person to match backwards to know, okay, what happened in the life of the person, and also to know how to help the person to come out of the hole where the person is. Also, as a priest, I attend to spiritual. When you have what I have tried, first of all, someone will come and say, I'm possessed, but I have a devil inside my stomach. So, well, I believe in you, but I have to explore other alternatives before I accuse the devil. Now, I begin to ask him about the person of the past life. Then one of the aspects of depression is that because of the history, the life history or the family history of the person, or the way of life of the person, or even the diet, or even the problem one has had, may make a change in the imbalance. Also, chemically or biologically, there are some elements in the brain function, whenever there is an equilibrium, or when there is a little bit of shift or imbalance, then the person will be thrown off. Then in such a case, if I discover such, I will say, now I can't attend to your problem, then we need to see a professional, a psychologist, or you go meet the psychologist in the person in the hospital. Another one, I will ask the person, first of all, have you been taking some medication before? Have you some prescription? 40% of them will say yes. But now, did you take it yesterday? No. Okay. Now you say that the person has refused to take the medicine, and at the point, there was an imbalance in the case. So, but now, for me, the bottom line is to listen to them. Listening solves a lot of situations. Most of them have no one to listen to them, especially those like the aged, the old people. They have no one to listen to them, even some of the youth. So one of the things I do is to give the person the sufficient time he or she needs to, in order to get rid of what what he has right inside her. So by also doing, I give the person time to come, just I march along with them, I just work with them. Okay, thank you. Okay, I thought you were giving me time to start. So I'm also not because of my colleague, I want to instill on secret on the colleague page, no. So even if you are a Protestant, wherever you are, aware the person, have you been going to the church regularly? But most of them, it's because of the spiritual dryness. And the person has, because there are two things that control a human being, the body physical, and then the spiritual. If the spiritual is not taking well care of, there is a physical problem, because there is an imbalance in the two elements that make up a human being. There is also an imbalance in the direction of the person. So I tell the person, if you are carrying pain, you have a pain in your pain. Go to confession, then so many things will be taken care of. Thank you.
So if I can summarize, you've drawn for us the connection between the spiritual and the mental. You've shown us your picture therapy, but you've also shown that you and your priestly work are providing these services yourself, and that you're doing it in a culturally appropriate way. You're looking at where the person's coming from. So if they come and say, well, I'm possessed, you say, well, that's possible, but let's look at some other things too. So you're addressing their cultural standpoint and taking that aspect, that it could be possession, but it could be a mental health issue. And then you're using the client history to figure out where to go next. So it sounds like you're doing a very thorough job of looking at the whole picture. If I can draw everyone's attention to the several pieces of paper we have on the board, what we see now is on an individual level, people providing services in one way or another through their own means. And some people having more means than others. Some people mentioned very clearly, the PHQ-9, for example. And other people said, well, I talked to the person, I listened empathetically. So people coming from different places to provide the services that they can provide based on their knowledge and their skill base. So I'm going to ask you to take one step back. We've heard these stories of the individual. Let's take one step back and ask the question, when we look at our whole community, when we look at this whole area in which we live here in SPA 4, what do we see as being the situation on a macro level? This is the micro level. This is the individual level. What's the situation on the big picture? We now see some examples of the small level. What's the bigger level? What is the situation for our community when it comes to seeking care for depression?
There's no facilities to provide the services.
Let me restate this one more time before I give to the speaker. I think we all know that there's, a great lack, a great limitation. But I want to flip it on its head. In spite of that limitation, what is it that we have available?
Their own community. We're there to help each other, although they don't have the services, the facility to provide these services, but we're there to listen to each other.
I strongly believe in support groups. I think that when mothers come out of the hospital, there should be some type of program that invites them to come back and meet with other mothers and maybe exercise and do something productive. Meet other mothers that have that same problem. That would be great. So I think support groups would be a key in helping people with depression.
And you're kind of saying that those support groups don't exist right now?
Probably, but I don't really see the community getting engaged. So maybe there's not enough community outreach or information out there.
If we really look at our assets, we have spiritual support, we have temples, we have churches, we have some schools. So it's about teaching people how to access those resources. There's parks, and parks are a true support for anyone that's going to. There's activities in the community. It's how do you engage and how do you access them is the true question.
Okay. And I think that's what I was asking, actually, is how do you see the community? What's out there? Anybody else?
I'm coming. On the way, I'll tell you, LA City Parks and Recreation is an active partner on CPIC. So we will have the recreational component. And, sometimes those things, just like exercise or just, getting people out the door is the important thing.
I think a lot of times the agencies and the providers underestimate the power of informal support. And I think that it's really on us to be more creative in engaging the informal supports of the families that we serve. Even if it's helping a parent ensure that the family does not crumble or fall apart when we pull out. We have to strengthen those informal supports, whether it be the pastor, the minister, the preschool teacher, the elder in the community, anything like that. That's really vital in the work that we do. So making families really collaborative partners in the services we provide.
I think it's important to be very intentional about building community. Actually, in Spa 4, I think we probably have more resources than most of the other spas just because we're centrally located. But our communities are fragile, largely because of the huge demographic changes that have happened in Los Angeles over the last 20 years. That, just to give you an example, when I first came to Church Epiphany 7 years ago, we didn't know anybody, so we took pictures and we put them up on the wall and so to identify, and I said, for me. In truth, everybody else was going to that wall and they were looking at those names and saying, oh, that's who that is. Now, they had been going to church there for a long time, but they never knew each other, never really knew each other. And that was also true in our first efforts in the health. We had a health promoter, and the idea was that they would build on the trust networks. Well, in fact, people didn't trust each other. And again, that may be just in my neighborhood, but I think that's probably true in most others. So where there are parks and churches and things like that, don't take it as a given that those networks are strong. I think be intentional about rebuilding those networks. They can be strong again, but it's going to take some work.
One of the things that we've heard earlier are the stressors in our communities now, especially in the Antelope Valley, is hardest hit by the housing collapse. We see a lot of families, I see walking patients almost several days a week. They're experiencing a lot of stresses in their lives, meaning they lost their jobs, they lost their houses, what do we do? And then, of course, there are cultural factors that, I don't really go to a therapist, why am I here? So, the first thing that we do is to normalize and acknowledge that they're seeking help. Kind of normalize that, yes, it is okay to ask help. This is the first thing that people have to build their strength, meaning it's okay to ask help. It's not that you're a weak person for asking help. And then we offer them how to navigate the system. What are available resources in the community? And then what can we offer you? And what can you do for yourself? It's a collaborative model, meaning you don't just ask help for somebody to fix you. It's like not the fixing effect. It's you to help yourself. We're just there to help you. So it's you always to help yourself. And I think this is a very, very strength-based model.
Thank you.
One of the things that I'm a case manager from Fountain Mental Health. These are my colleagues, and I have some clients here. One of the main challenges is working with the client because they have a lot of negative self-talk. Another main factor is the lack of support from their own families because they're not educated on what the client is going through, and a lot of times the client does not understand the different processes that they're going through. One of the things that we do as case managers is we try to help them laugh. There's a meditation class group that's offered. We also have a healthy living in Spanish, and we try to get them to smile. In my case, I try to discuss different stories of empowerment for the clients. For example, during the AIDS epidemic in the early 80s, Brazil had a large population of people with AIDS, just like we did in the United States. But in the United States, the families were placed on quarantine, and those clients were dying faster. Now, they didn't know why were the people in Brazil living longer. Well, they realized that they had more community support, and a lot of people would go to them, talk to them, and encourage them. And I think that's a big factor in dealing with depression, to keep the hope. Also, eating healthy and exercising is another component. Thank you.
There's kind of a theme running through this that there's a lot of resources in the area, but not everybody knows where they are. They're not connected. I'd kind of like to hear from some of the folks who haven't made comments yet, but how do you see this group, for example, addressing that issue? What do you think is needed for us to come together and do what the Padre here said is needed to do, and that's really move towards bringing people together and building that trust issue. Anybody have any comments?
Well, I have comments, but I've already spoken. More comments. I have several different comments. I mean, I think what's needed to what you just said is that you need at least a few individuals that are devoted, committed to the process, and that's the main thing. You have to have. You can't just continue to bring everybody together. At least that's been my experience in other community organizing venues. And in my small community in Hollywood, we have done a lot of cobbling together of what we term loosely community case management, because there are a lot of us in the community that were brought together for different reasons that found that there were no resources for people we were dealing with. Somebody, from a church, somebody from the business improvement district security, somebody from the law enforcement, somebody from homeless services. So because we saw that we had a common need, and I deal with homeless people, so I mean, you're hard pressed to find somebody who's homeless who's not depressed, so pretty much that's, a given of what we deal with. But all the other resources, like I love what this gentleman was saying at Palmdale Mental Health about the things they have available for people to just engage them. Unfortunately, the things I know about in my community mental health resources are not accessible. People have to meet specific criteria, and most of the people that I'm dealing with don't meet that criteria. So it's an access issue. I'd love it to not be stigmatized like that if there were open and available recreational community resources that people felt, that anybody could go to, that, was comfortable. As it is, what we do is we refer, I'll call up the pastor at one of my churches or another community organization I know and just talk to them about the client that I'm really concerned about, or my case managers will do that, and just say, do you know of a support group that might fit, this person? But it's not a strategic sort of process, is what I'm saying. We're kind of still operating in that crisis mode. So, that's not.
How many of you here are actually involved in some sort of coalition, partnership, collaboration? How is that working? And what can be done to improve what you're involved with right now?
Work without being involved in coalitions and collaborations. It's just, nobody can exist in a silo anymore. And going back to some of the previous comments, we've been finding that neighborhood-based really works well. It's hard to ask people, even when the resources are there, and the resources are there many of the times. It's really hard to ask people to go out of their neighborhoods, to travel, particularly when they're depressed. It's better, we have found it better to bring the services where they are, in non-threatening environments, whether it's in their home or community centers or parks, etc. So basically, neighborhood-based collaboratives have worked better for us.
I agree with that. And let me just ask one more question then. How do you see, or do you see, the possibility of connecting those neighborhood-based coalitions? Make a larger group. Is that possible?
Well, I'll give you an example from the nurses. So I have a group of 20 nurses. We work in over 60 churches, community organizations, and we try to cross-pollinate. So we've created a network. We've been in the community for 15 years, and so we have kind of an established trust base. So that's a good thing. But what we try to do is cross-pollinate, where we bring everybody together and get them to learn from each other. So we have some outstanding volunteers that go from church to church to talk about developing a health outreach program. So they don't hear it from me, they don't hear it from the nurse, they hear it from a community representative. So trying to do that cross-pollination and spreading the word in a way that you can hear it. So a lot of community members maybe couldn't hear it from me. They might not be able to hear it from my nurses or staff, but they can hear it from another church member.
Okay, we're kind of running out of time here. Any comments about how you might see this group doing some of these things? In the course of the discussion that we've had today, you see that this group has the possibility of doing some of these things that might improve the system.
Over here. Yeah, I do. I think one of the things that's important too is it's a support system for us. Because I know a lot of times, if I'm in like a West Side homeless partnership, and just being able to talk to other people who are seeing the same things that I'm seeing is a way for me to sort of feel better about it. That I'm not the only one seeing the craziness that's going out on the streets and the people that are experiencing mostly homelessness is what I'm used to working with. But I often come out of meetings with the partnership, maybe I've learned something from other agencies, but it's also just, I feel better that there are other people out there dealing with the same issues that I'm dealing with, and that I don't feel like I'm alone out there. And I think that this is a great place for that type of thing too.
So then to amplify your point, when you have those kind of discussions, what priorities emerge from that? Or what priorities emerge in your minds, anyone here today, when you hear these things? What comes out to be, in your mind, the things you should focus on?
I guess we learn from each other just to try to help that client that is in distress that we're not able to refer them to a facility to receive this treatment. And we're more educated to help them at least at that point of time. Or, unless it's really drastic, because it's like we're in the San Gabriel Valley. If the person in us is not bipolar or schizophrenic, we cannot refer him to the mental health because he needs to be like all the way completely out of their mind, or else, there's nothing in between. So I think by learning from other people, we have that education and learning from others, and then take whatever they're using, and then, maybe that will help my client, and then we could just approach and teach that client to help themselves.
So then a priority is your own self-education in order to increase your own strengths, your own knowledge.